I'm Peter Block for On the Scene at TCT, and it is day 3. For those of you who thought that renal artery denervation was dead, think again, it is not. With me is Stefan Desch from Lübeck in Germany, and Stefan has just reported on a trial with mildly elevated hypertensive patients. Stefan, tell me about your trial. What did you do?
Yeah, these are still resistant hypertensive patients, but only mildly elevated blood pressure. How did we come up with the definition of mild? It's 135 to 149 millimeters of mercury daytime systolic blood pressure, or 90 to 94 diastolic. So this was our population, which is quite different from the Simplicity HTN3 population. The definition of resistant hypertension was, as usual, 3 medications, including a diuretic at optimal doses.
So patients who are difficult to treat, tricky, but not terribly hypertensive.
Yeah.
And you went ahead and did renal denervation. And what catheter did you use, and what did you do?
The Simplicity Flex catheter, which was a catheter that has been used in all the Simplicity trials, so none of the newer generation trials. And as a control, we had a sham-controlled procedure. Yeah.
So you actually did the procedure without turning on the button?
Yes, exactly. We did a femoral puncture, obviously, a renal angio. We had this little alarm clock which was ticking for 2 minutes each. We tried to simulate the exact same procedure length as in the real denervation procedure. We had the same room set up. We gave saline infusions to simulate IV pain medication. So I think it was a pretty good sham control.
Okay, so I guess we have to cut to the chase. What'd you find?
Our primary endpoint was the change in 24-hour systolic blood pressure, so ABPM primary endpoint as opposed to the office-based endpoints in the Simplicity trials. We found in the intention to treat analysis a 7.0 millimeter of mercury reduction in the renal denervation group and 3.5 millimeters of mercury reduction in the sham group for a non-significant p-value of 0.15. However, when looking at the per protocol population, which was not defined as the primary endpoint, we found a significant difference between the two treatment arms at a p-value of 0.04.
So this is a relatively small numbered trial, right? About 75 patients. That makes it a little difficult to really understand the p-value, but certainly a signal that something is going on that's good for patients that have hypertension.
There seems to be a biological signal, and if you look at the per protocol population, which is probably a better indicator of biological effectiveness, there seems to be a significant effect.
All right, so is your plan to move ahead and do a larger trial, or what do you think should be done in order to sort of figure this out?
Yeah, we need a larger trial. We need trials with a different design, both with respect to the technological side, the technical side of the procedure, and our patient selection.
Okay, thanks, Stefan. So for those of you who thought that renal denervation was gone, it has certainly not gone, and I think now we have a biological signal that in resistant but only mildly hypertensive patients, there may be a very strong effect. We'll see how it all turns out with future trials.